First thing I was say how grateful I am to be here. I think that as for most of you this afternoon, it was a very important conversation. I learned a lot, and I'm sure you did as well. Learned a lot. What I would like to do is, I say it's very rude that when I was reviewing the material for the day, I realized that there were a few things that will help me make my point this afternoon. And it's a presentation I gave a couple of weeks ago to a board of a large Canadian organization, but I don't want to impose the presentation on you, don't worry. I just want to use that to make a point. So I'll show you two slides, basically. So this is my starting point for those closing remarks. Some of you, especially those who have been trained some time ago, will recognize this equation. This is Donabedian, famous page 65 of Aspects Medical Care Administration. I think people in my generation, we could have that tattooed on our chest. Basically, this is the basis for, this is the founding text of health policy, basically, and most Department of Health Admin that have been established in the US and Canada have been established according to the lessons of that particular book. Donabedian did that before he was engaged in the quality movement later on. And the idea that was very important at the time was that what his health policy is a series of interventions, partly based on instinct, partly based on tradition and institutions, partly based on evidence, fortunately, that are trying to create a balance between needs, services, and resources. So departments of health admin were conceived with people that will try to evaluate and define what are the needs of a given population. You will have people that are doing what was called at the time medical care administration that will organize services to meet those needs, and you will have health economists that will try to decide what kind of resources, financial, human resources, and so on and so forth, that are needed to provide the services. And basically this is what we have been doing for 50 years, trying to find a balance between the three. At the time of the book in 1973, there was the idea that this could happen through some form of invisible hand. Donabedian was writing this book in what was a market economy in which health was seen as essentially a commercial product, but of course we discovered very early on that you need some form of real adjustment, and this is what health policy people are doing. This is our particular lens. When I say I come to health care and to health policy with that a particular lens, my lens is that one. How could we actually make sure that we have some form of balance between needs, services, and resources? The reason I wanted to show you that is not to show you how clever I am, but to show you that there was one thing at the time, is that the question of needs was not questioned. The needs were seen as evident. It's something that could be easily measurable. In fact, Julio Frank, very famous text in which he made a difference between needs and wants, was published 5 or 6 years after Aspects of Medical Care Administration. And at the time of Frank's publication, patients' wants were dismissed. It was basically to explain that there was a difference between the wants of patients and their needs, and that we didn't have to pay attention to their wants. Our role, which was very paternalistic, was to precisely define the needs of the patient, whatever they may think about their wants. It's very clear, and this is why I decided to use that today. And this is one I found very fascinating in what Catherine presented, is that I think we have moved away from that world at this moment. Nobody will be happy with a definition of needs that will just be done by specialists without any attention to the wants, to the voice of the patient. But of course, there is a tension there. We cannot just replace needs by wants. And the problem is, how do we create what you have called a relationship? How do you create a conversation between the health system and the patient that will let us reconcile needs and wants? And I think this is one of the very important lessons of this afternoon. And of course, this is where Canada is very advanced in that particular domain. I have colleagues that are now international superstar. It could only be done through shared decision making, and shared decision making is not something you could just do like this. You need tools, you need training, and of course we need to think a lot about how to do that in a very systematic way and how to equip ourselves with proper tools. So that for me was a very important lesson of the day, the recognition of this tension and the fact that performing system, like the one you have presented this afternoon, are actually trying to address this and to address this with proper tools. The second issue that I found very interesting in the presentation is, of course, the convergence between, we may not have used the same language, but basically we're all addressing the same issues. And it's true at this moment in most developed health systems. We are trying to achieve the same type of results. Of course, we all want a strong primary care health system. And again, I won't impose my own anecdotes on you, but it's clear that this is an issue everywhere at this moment. How to do that? We don't necessarily know how to do it, but we all know this is absolutely essential. We know that we have to provide a much extended range of services and goods than the one we have. As you know, for Canada at this moment, the priorities have been identified: mental health, pharmacare, and home care. But why not dental care? Why not vision? And of course, the conversation that we just started to have, that has started in the US because of the Accountable Care Act, where a big hospital system has been starting investing in housing, in employment, in education, because it can be done. And this is part of the questions at this moment. How to produce effective care teams. We'll go back to this idea in a minute, but the conversation today, I'm sorry to say, has been extremely physician-centered. And I'm sorry, in 2018, really, just talking like if the system was basically physicians and patients, that's impossible, that's not true. This is not what we want to achieve. Creation of established pathway, very interesting that the terms integration has now nearly disappeared, which is probably very good, and that we're starting thinking in terms of pathways. Shared decision making, I mentioned. Again, I will go back to that in a minute, but we haven't been discussed very much about data and the importance it is taking at this moment in the evolution of the system. And finally, this idea that we should have outcome-driven investments in the system. This is your point, at the end. And we could show that there is better health outcomes could be achieved by investing elsewhere than the healthcare system. And if you want to be serious about cost, we need to start discussing that. We need to be aware that maybe we should, put a cap on health expenses and start investing more in education, investing more in housing, investing more in sustaining and supporting social relationship and family structures and so on and so forth. But the convergence is evident. Again, you look at the presentation about Scotland, you could look at the presentation about the US, about France, and you will see those same categories appearing on slides, presentation after presentation, because this is our task for the 21st century. Third point is the point you made, Brendan, about cost, and it made me very nervous because, of course, I think we know that information is not enough to change behavior. I think we have tested that for 20 years now. We know that's not enough. So what will make disinformation part of a behavior change? And I think this is where my thinking is at this moment. Again, and how do you reconcile that with a system in which you do share decision making, in which you give a real voice to patient, not just, and by the way, is there anything I can do? No, in which they are part of the decision-making process. As you know, cost doesn't mean the same for, this is a point that Chris made earlier, cost doesn't mean the same for everybody, and so my fear is that if we don't do that very carefully, we will see even more variation that we are seeing now rather than less, because decisions will be made by individual physicians. And in a way, this is the four questions that for me have not been addressed fully today, and will need attention in the future. The first one is clinical governance. For this to work, this kind of information, you cannot leave an individual physician in front of an individual patient making a decision based on cost. Again, if you do that, you will have an incredible increase in variation very, very fast in the system. The systems that have been able to do this, because there are systems that have been able to introduce those kind of variables in the decision-making process very successfully. All of them have as a main characteristics the existence of a strong system of clinical governance. So if Mrs. Jones, requires something that is costly, that is out of the norms of value, etc., the system will let you outright the system will let you outright the norms, but your colleagues, if you're doing that for all your patients, will start asking you very important questions about your behavior. And those systems work well because those decisions are not individual, they are not taken, but are seen as part of the practice of a team, of a group, in which you have a patient voice represented and so on and so forth. The second question we have not discussed very much, this is very close to my current preoccupation, but it's capacity. And how do we make sure when we do those changes that we have people that are actually able to implement, monitor, and do that for long enough so that don't get completely burned out after 18 months of change or transformation. The other problem with capacity is at the national level. We have evidence, a lot of evidence, that reforms that are made at provincial level and that are not disseminated do not tend to last very, very long and tend to be abandoned easily. So how do we make sure that if we create some form of Alberta innovation that is highly performing, highly important, how do we make sure that this will actually be disseminated elsewhere in Canada, and that we will have some people that will start saying, oh yeah, this is the good way, so that we could train a generation that is able to think that particular way. I mentioned my third issue was I found again that the discussion was very physician-centric. There was a strong clinical bias in our conversation this afternoon. And again, the social determinants of health was mentioned at the end of your presentation in one question at the end of the question, but I think we really need to have a serious conversation about this. This is really the frontier. And again, what I have seen when I was in the US is that we are starting to be able, because we are starting able to measure that, we're starting to be able to measure the influence of social determinants of health, not only at population level, which we have been able to do for a while, but now nearly at this granular level of patient and at least families. So I think this is quite important that we start thinking in that way in the future. And I want to end on the question of data. So we haven't discussed much about that today. Just a few years ago, there was the promise that was made to us very clearly that we will be able to monitor transformation and policy in real time. It's one of the big problem issue in public policy is the capacity to monitor the implementation of policy in real time and do adjustments to policy. The only model that we have normally is that you implement a policy based on the best evidence and input from different stakeholders, and then you try it for 1 or 2 years, then you ask Braden to create a research project that will do an evaluation of the impact of the policy. You discover it doesn't work exactly as it should, and you will adjust your policy. It takes a lot of time, but people in the data world were telling us it's over. You will be able to see what is happening nearly in real time and do the adjustment. Of course, it didn't happen, as you all know. A lot of the promises that were made by people that were talking about data, and I think this is what will happen with AI, by the way, and in large part, for all of those sort of reasons, those promises have not been kept. But on the other hand, and I think this is something that we should discuss as a community, is that the private sector is engaged in that world of producing data in a way that will have an incredible impact on everything we're trying to achieve now. You've seen the announcement by Apple 10 days ago about the last generation of Apple Watches, and the fact that our emergency room will be overwhelmed by the number of people that will now say, oh my God, my watch is telling me I'm on the verge of doing some form of cardiac arrest. I need to see someone. Data are produced about your health continuously by private sector, and you will start paying attention to that. So if we don't find a way to manage that interface, again, we will be completely overwhelmed, and a lot of the things we try to achieve will basically fail because of the attention that will be created by that pressure. Again, a fascinating conversation, a great afternoon. Thank you again, John and Chris, for putting that together. Thank you, Catherine. Thank you, Braden. Thank you. And thank you all for your patience and your attention. Thank you.